and the passenger. You have an issue with the pump, which is the heart. Many times you'll have cardiogenic shock because the heart cannot pump. If you have an issue with the passage, which are the blood vessels, then many times distributive shock, the septic shock, anaphylactic shock, neurogenic shock lie here. If you have problems with the passenger, these are usually problems associated with volume. So low volume, and the commonest type of shock that we get in trauma is the hypovolemic shock. Hypovolemic shock that is hemorrhagic. Sometimes you can have non-hemorrhagic sequelae mechanisms, but many times it's hemorrhage. You lose blood, so you end up in shock in trauma. So there are about 4 types of shock that can ensue in trauma. I'm sorry for this slide not being so clear, but when we look at hemorrhagic shock, we tend to subclassify it according to degree of blood loss from class 1 to class 4. You realize that patients with class 1 hemorrhage usually have lost about 750 mL of their total blood volume, which corresponds to about 15% of their total blood volume. And their vital signs are more or less normal. The urine output is more or less normal. Their mental state is more or less normal. As you move towards the higher classes of shock, you begin to lose more blood. By class 3, you've lost up to 1.5 liters of blood volume, which corresponds to 30-40%. And the vital signs get deranged. The pulse rate increases, the respiratory rate increases, the urine output starts to reduce. By the time you get to class 4 shock, then the parameters and the vital signs have changed according for the worse. So we have a tendency to classify hemorrhagic shock into those 4 classes. And it's a very quick check when you have a patient to try and see where the pulse rate is, what the BP is, what the respiratory rate is, what the urine output is. It could help you grade the kind of shock that the patient may have. So at the back of our minds, we always have this approach to management of the patient. Even when we are headed into surgery for a trauma patient, the phases do not change much. There is the pre-hospital phase preparation, then there's an intra-hospital phase preparation, which you must have seen last week, where the people in the emergency room will prepare the necessary equipment and prepare to receive the patient and all these monitors. Then the patient gets there, or if they are patients, and there are many, there's a principle of triage. There's a principle of triage where multiple casualties are dealt with, mass casualty situations are dealt with. Then after you triage, and now you have your victim, you subject them to a primary survey. A primary survey with resuscitation, you find the situation, you intervene immediately. The primary survey is airway with cervical spine protection, breathing and ventilation, saturation and control of hemorrhage, disability or basic assessment of the neurological status, exposure and environment without causing hypothermia. And immediate resuscitation, you discover something wrong with the, something with breathing, and then you correct it immediately. And the adjunts, or things you can do to help perform the primary survey properly, to help execute whatever you need to do in the primary survey properly. Things like pulse oximetry, chest x-rays. These are adjuncts to primary survey. And then the need, you consider the need for patient transfer at that point, because sometimes you may do your primary survey and you discover the patient has a GCS of 6, and probably what they need is a CT scan and a neurosurgeon. At that point, you consider the need to transfer. But more or less, after the primary survey issues are sorted, we move into the secondary survey, where we usually take an ample history and the head-to-toe analysis of the patient and the log roll of the patient to check for injuries in the back. And we perform a digital exam for some of those patients with a high riding prostate, with urethral injury, with neurological injury. By telling the anatomy, would be able to get some clues. So we have to perform a log roll. And then the adjuncts, some other things you do, you use subtle catheters and all these things to help you monitor the patient. You do an ECG, these adjuncts to management in the secondary survey. we always continuously reassess our patients and take them to definitive care. Definitive care is what we are going to, I think, to tackle surgically now in the zest of this presentation, because we want to see these trauma patients that are presented with trauma issues, what manifestations surgically can they have that need intervention of the surgeon, and what can we do to help keep them alive. So we pay attention to the ABCDEs of critical surgical interventions. And if we're just to focus on the airway, and if we're just to focus on this picture, for a patient who has a difficult airway like this, has facial trauma as terrible as you can see, you really tell that the people who intubated were lucky enough to intubate such patient with foreign body secretions, hematomas, edema, facial bone fractures. It may not be very easy to get a definitive airway. A definitive airway means a tube in the trachea cuffed, and you need it to keep this patient alive. That's a priority. Sometimes you may have to do a surgical critical thyroidotomy, where we introduce a tracheostomy tube, this procedure here. Okay, we extend the neck to expose, try to expose the tracheal rings. We palpate over the cricothyroid membrane, and then we use a guide and make a horizontal stab through the skin, and then quickly introduce the tracheostomy tube. As we see, it's a life-saving maneuver. It's a surgical maneuver. It's life-saving in case you have facial trauma, gross facial trauma, or for some reason you cannot access the face to do the routine intubation. So the airway. Sometimes, issues may happen. It may dislodge. This artificial airway you have what may dislodge. The cuff may get deflated for some reason. So it has to be subject to constant reassessment. And if you had injuries to the airway that are distal, like the trachea or the bronchi, the mainstem bronchi, these are potentially very fatal. We shall say this in the latter slide. So if we move down to breathing, and maybe just come down to the neck and the chest, the commonest chest trauma injuries that are fatal include pneumothoraces. And pneumothorax can be simple. It can be tension pneumothorax, it can be an open pneumothorax. Hemothoraces, flail chests, and pulmonary contusions, cardiac tamponades, injuries to the trachea and the mainstem bronchi, disruption of the thoracic aorta, injuries and ruptures of the diaphragm, and then ruptures of the esophagus. So what goes wrong physiologically? Chest injuries often result in hypoxia, hypercarbia, too much buildup of carbon dioxide, and acidosis. When you have blood loss, the chest can really sequester a lot of blood up to 2.5 liters. You could end up with hypovolemic shock. You could have ventilation perfusion mismatch issues, especially when you have contusions. You have surfaces that cannot ventilate. Okay, you can inspire and expire, but you can't ventilate. And then conditions like pneumothorax and hemothorax increase intrathoracic pressure. And because the process of venous return, for you to generate a cardiac output, you need a very good venous return. And the process of venous return many times is a passive process. So blood coming back to the chest cannot afford to meet increased intrathoracic pressure. Otherwise, you'll have a poor venous return. So you have a poor venous return, then you'll not have a cardiac output to generate. So that's the mechanism of shock, sometimes as obstructive shock. So this can give you tissue hypoxia and eventually metabolic acidosis.
Yeah,
and hypercarbia can also. Pardon, is there somebody?
We cannot see the screen, unfortunately. We are not following because we can't see the screen.
Or is it you cannot see my screen?
I beg to know which slide you said I can share it from this end.
Oh my God.
Which slide are you? I can share it from this end.
Slide 13, but let me try to reshare my screen. Sorry. Oh. Oh my God. So you have not seen my screen?
Okay, is that where you are?
Can you see my screen now?
Now we are seeing.
Oh my God. I wish somebody warned me earlier. I'm so sorry about this. I'm sorry I've gone as far as this. Can you see my screen now? Yeah, I'm really sorry. I'm really sorry. Okay. Now, can we proceed now, Dr. Mukembo?
Yes, let's proceed, doctor.
Yeah, I'm really sorry about that. Tension pneumothorax, and there's a picture here of a tension pneumothorax, showing the devastating effects of a tension pneumothorax on the left side, how it will cause collapse of the involved lung, and then push the trachea to the opposite side and render all this area on the left side useless and push associated mediastinal structures to the opposite side. So how shall we see that? The patient has distended chest pain, they are in respiratory distress, the trachea is deviated to the opposite side, they have a hyperresonant percussion note, they have breath sounds absent on that side. And how do they get in shock? Either be because they have obstructive shock, because they have increased intrathoracic pressure and poor venous return, that could lead to tachycardia, could be evidenced with tachycardia and hypotension. Cyanosis may be a late sign because they have a compensatory lung the other side that is doing some work. So almost close to 90% of chest injuries can be managed with one simple maneuver, insertion of the chest tube. Initially, when identified, we decompress the chest with a fine needle decompression, a large bore cannula in the second intercostal space. And the new ATLS principles now advise that because we have different sizes in the chest, especially for adults, they want to advocate for the needle decompression to be done in the fifth intercostal space instead of the second intercostal space. So that is turning slowly. For children, it remains the second intercostal space, but for adults, it's changing to, I think, the fifth intercostal space where you decompress chest. Insertion of the chest tube remains fifth or sixth intercostal space, just anterior to the mid-axillary line. And this is a surgical procedure, it's a sterile procedure, and it's a very life-saving procedure that should be emphasized. And I tried to get some pictures showing how this procedure is executed. Usually, if we are targeting the fifth intercostal space, then we just have to go just above the sixth rib, just anterior to the mid-axillary line. Having given local anesthesia and prepared ourselves, we make an incision there that is about 1 centimeter long, having prepared everything that we need. And then we open up the fascia there, keep opening the fascia, we could widen it with a finger, and then we grab our chest tube, introduce it, clamp it, and secure it. It's a very life-saving maneuver, insertion of the chest tube, that I need to talk about here. An open pneumothorax is detrimental because it creates a valve, a situation of a one-way valve where you suck in air and it escapes and you do not maintain intrathoracic pressures. So we have to put an occlusive dressing so that the only thing that can happen when inspiration happens, the chest burrows out and we close up this defect. Air cannot escape into the chest, and when we get out, when we expire, air can escape. So we place, this film with 3 edges occluded to allow for that process to happen when we have an open pneumothorax. Flail chest is another unique injury that happens to the chest, we have fractures happening to ribs at more than 1 point or more than 2 ribs. That gives you a segment that is literally floating. So you inspire, instead of the chest, blowing out, the flail segment sinks in, and when you expire, the opposite happens. This interferes with your pulmonary pressures. So to improve this, we have to occlude the whole area with a uniform dressing, and then give analgesia or some nerve blocks. If it's too severe, we may need to intubate the patient in the interim and inherit the process of ventilation. But flail chest, yes, is a unique situation that we need to take note of. So what is it that we call a massive hemothorax? You can have a hemothorax managed in a similar way, more or less, to the pneumothorax. Though this time around, we may not have a hyperresonant percussion, we shall have a dull percussion. And when we put in our needle to decompress, breath sounds will be absent on both, but when we put in a needle to decompress, we shall not receive air like we're doing in pneumothorax. So if you have blood and you are accumulating more than 100, 500 ml of blood in the chest cavity, and you get those findings on clinic exam, mainly if you had a patient with penetrating chest wound or had very severe blunt trauma, the patients you need to monitor closely. You put in a chest tube, you've been treated for more than 1,500 ml, or you're continuing to get more than 200 ml per hour of blood despite continuous resuscitation. It's indicative good to have severe and a large vessel in the chest, and may need a cardiothoracic surgeon to come and do a very quick laparotomy. Cardiac tamponade is another issue. Cardiac tamponade, we have blood accumulating in the pericardial space. It may develop slowly over days. It may develop rapidly, especially if it's severe trauma, characterized by this triad of hypotension, distension of jugular veins, because the contractility of the heart is limited, blood cannot return with ease, and muffled heart sounds. There could be a co-small sign, or if somebody expires and there's rise in venous pressure, it can easily result into pulseless electric activity, and these are cardiac arrest algorithms, rhythms, and may have signs similar to that of pneumothorax. Very quickly identified nowadays with the first window of the first scan, the pericardial window. You see fluid in the pericardial space, and we need the surgical intervention. The pericardiocentesis, the needle angled at 45 degrees and geared towards the pericardial space, usually with radiology guidance, to drain that fluid. It may not be enough. We may need to have a pericardial window by a thoracic surgeon to keep the space open to allow for contractility of the heart. This picture demonstrating approach to management of pericardial fusion with approaching the pericardial space with this thing at that 45 degrees to just below the xiphoid process, aim towards the tip of the shoulder. So other little injuries in the chest. I'm not going into.
They go to where finger.
I'm not going into. Are we okay? I'm not going into very deep detail in the chest because there are so many other parts of the body and the time is limited. But injuries to the trachea and mainstem bronchi, many times these are fatal. If they are partial injuries, then the patient will make it to the hospital with hemoptysis and emphysema as they leak air, and it can be palpated subcutaneously. You could have traumatic aortic disruptions. These are usually fatal injuries if it's severe. For the survivors, usually they have a hematoma that is holding on to the tunica. So that, yes. Esophageal ruptures diagnosed with endoscopy is also common in severe force chest trauma. Diaphragmatic rupture, they are common on the left side and the right, because the right side has the liver layer protected diaphragm. On the left side, the complication could be herniation of bowel, stomach, and all this bowel that could strangulate and give you repercussions of strangulation. Lower rib fractures, yes, usually associated with abdominal injuries because these are abdominal ribs. Abdominal injuries. These injuries can be blunt, they can be penetrating, but the most commonly injured abdominal organ remains the spleen. The liver is quite commonly injured as well. In that order, as you can see on the screen. The least injured being the blood vessels. And the pattern of injury, usually when you inspect, it's important to look at your patient, especially for the light-skinned individuals. If they have a seatbelt sign, then you can imagine the injuries they could have. Usually the most exposed bowel in the abdomen is the jejunum. If they have a lap belt sign, usually it's the bladder. If they had a full bladder, it could be the bladder involved. If there was a side impact of the abdomen, usually the liver, or a pathological spleen. Pathological spleen, usually the enlarged spleens. Sporting injuries pierced by the horns of a bicycle, this happens usually to perforations happen to the jejunum, bicycle handle, by injury, pancreatic injury, but more commonly jejunum, or you could get hit by a cow, the horns of a cow, and perforate small bowel. So when you look at this picture and you see this guy with a seatbelt sign, you can only assume how much trauma he has gone through. He has both blunt chest trauma and probably blunt abdominal trauma, and any organ around that part could be injured. So penetrating abdominal injuries, when we begin having stab wounds, if it's one stab wound, it's usually confined to the track of the wound. However, it's important for you to explore properly. So we say in surgery that any stab wound that reaches rectus, you must do a laparotomy because you just never know what could have gone there. Penetrating wounds that like gunshots, like blast injuries are very unique because they have such a very unique pattern of injury, depending on the distance from the offender, depending on the type of gun, depending on the nature of the bullet, depending on the kind of projectile. So gunshot wounds, I'll classify them with bomb blast and those things. They are very unique injuries, and you need to take clear note and admit these patients, keep them around. And work out, it's important to have the anatomy of that whole abdomen at the back of your mind, work out the path. I remember there's a time during the riots in 2020, November, where we got a patient who had an entry wound on the right side, the right upper quadrant, and an exit wound in the left lumbar area. And we did the laparotomy. We found, of course, grazing of the liver, perforations run through to the stomach, perforations run through to the transverse colon, perforations of the jejunum, and then part of the ileum was exteriorized, grazing of the inferior pole of the spleen, grazing of the superior pole of the left kidney. So it's important. So there were multiple organs along the path of that one bullet that were injured. It's important really when you go to do a laparotomy and you open the patient up, that you take clear note, you work out the path of this bullet and try to explore all the structures associated with this path. Yes, in assessment, please don't forget the log roll. Sometimes you could find your evidence posteriorly. So expose your patient thoroughly from the lower chest up to the mid thigh and inspect the back as well. In assessing the abdomen, you don't forget the typical medical school textbook assessment. You inspect, palpate, percuss, and auscultate. So when you palpate and begin percussing, you want to look out for guarding. That could be a sign of peritonitis. You You want to do superficial and deep and rebound tenderness. And you want to look for pneumoperitoneum. Sometimes if we have visceral rupture, and it could be useful for you to detect an enlarged solid organ, distended bladder. You want to auscultate. Auscultation is rarely helpful in a trauma assessment. Inspection, palpation, percussion usually help. And you want to end that abdominal exam usually with a pelvic spring test, because you want to look out for open book pelvic fracture. Some of these patients who are in severe hemorrhagic shock, you want to find out the source of hemorrhage, and the visceral structure and the venous plexuses traversing the bony pelvis could be severed by broken pelvic parts. So you do a pelvic spring test to assess for stability of the pelvis, and if it's an open book pelvis, you want to deal with that immediately. There are some useful adjuncts that I cannot go without mentioning when you're assessing chest, the abdomen. One of them is direct chest abdominal X-ray, and we can already see some pathology for those who are medical. Area under the right hemidiaphragm usually points to rupture of abdominal viscera. And then the focused assessment with the sonography and trauma, nowadays abbreviated as EFAST, because there's a component to assess the chest also to look for pneumothorax, hemothorax, and rib fractures. But usually the traditional one had 4 windows. Okay, when you do this quick fast scan, had 4 windows, and the first window is the subxiphoid window, intended for you to look at the pericardial space and to look out for pericardial tamponade. The second window is this one, right up quadrant, intended to look at the interface between the diaphragm and the liver and the superior pole of the right kidney, or what we call the Morrison's position. The third window is this suprapubic window, intended to look at the interface between the bladder and the prostate in men, and the interface between the bladder and the uterus in ladies, so the pouch of Douglas group of fluid. The fourth window is this one, I think, is the left upper quadrant, intended to look at the interface between the diaphragm and the spleen and the superior pole of the left kidney on the left side. So those adjuncts are useful. There used to be the diagnostic peritoneal lavage. We expect the 11th edition of the Advanced Trauma Life Support manual this year, 2023. It had been emphasized in previous editions, this test, DPL, diagnostic peritoneal lavage, maybe, I think, because some areas are resource limited, they don't have a scan, and you want to work out, see, do I have hemoperitoneum, do I have rupture significant cause to need me to do a laparotomy? So you make an incision and introduce a trocar at the umbilicus, and then introduce a little of saline in the abdomen and shake the abdomen, get the contents, and then, analyze the content in the lab for blood and food content and bile. I think it's being deleted, it's invasive, it's cumbersome, and it can cause trouble perforation. So maybe the 11th edition of the ATLS, we shall not be seeing the DPL. But the CT scan is useful, though it should not delay management where you have a clinically deteriorating patient for whom you have obvious subtle signs of injury in the abdomen and you need to intervene surgically. However, if you have borderline symptoms, you have a child admitted, the scan has told you there's a ruptured skin, the child has a hemoperitoneum, you resuscitated them, the blood pressure is good, the hematocrit is there, the child is stable, it's 24 hours later, child is still getting a tachycardia. You want to work out how terrible the solid organ injury is. CT scan is very good with solid organ injuries, and of course, it's very good in neurotrauma. More or less diagnostic in neurotrauma, but solid organs in the abdomen, CT scan is good because nowadays we have 3-dimensional constructed images of those solid organs. They can be able to give you an image constructed of the liver, and you can see how deep the laceration is, and you make a surgical decision. So that's the only role CT scan has, but it should not delay your decision to go and do surgery if you have to, and you have some good telltale signs from your clinical assessment. So yes, you will have to repair. So what do we do in theater? We have a diaphragmatic rupture. We have to deal with it. We have to repair the diaphragm. We have solid organ injuries of the liver, spleen, and kidneys, and pancreas. Nowadays, we see pancreatic transections. We have to do distal pancreatectomies. We have to do pancreatectomies. We have to do nephrectomies. We have to evacuate hemoperitoneum. If we have organ injuries, like cellular injuries, many times jejunal ruptures, jejunal perforations, we have to repair them primarily. Or sometimes we have to give stomas if it's large bowel. If we have mesenteric injuries, we have to repair them. If we have expanding retroperitoneal hematomas, we have to explore those. And if you have an intraperitoneal bladder rupture, extraperitoneal bladder rupture can be forgiven. Intraperitoneal bladder rupture, we have to go and repair the bladder. And then pelvic fractures, we usually do damage control laparotomies to do pelvic peritoneal packing, or the orthopedics come in to do damage control fix for a terrible pelvis that may be continuously bleeding. Together with interventional radiology, sometimes you have a major vessel in the pelvic area bleeding, and many need an interventional radiologist to deal with it. The principle of damage control surgery is a principle that we address because many times it's a concept. You want to do a very quick laparotomy. You want to prioritize short-term physiological recovery over anatomical reconstruction. So you don't want to be very fashionable, making a proper anastomosis or doing a perfect repair of the liver or doing some of those perfect things. In damage control surgery, and we've done some of them, you have a patient who is decompensating very rapidly despite resuscitation. You want to go to theater quickly, achieve hemostasis. That is the main goal. Many times we live in clamps. We do packing. We could do quadrant packing. I will leave the parts there and we'll do temporary abdominal closure. Send the patient to ICU as soon as quickly as we think we have achieved hemostasis. And then after sending them to ICU, we stabilize, we continue to resuscitate them. Then about 30 hours later, we return them to theater. We don't want to take longer because whatever we've left there is going to become a foreign body and we're going to have sepsis. So we bring them back to theater about between 24 to 30 hours later, remove the parts that we left, and then we can do more definitive surgery. So damage control surgery as an aspect, as a component, mini component of damage control resuscitation, we do that. You need a very good team, you need very good prudent ICU to help do damage control surgery, but we do it, it's very life-saving. Yeah, so they can do it in thoracic trauma, we can do it in abdominal trauma. Blood pressures are not peaking despite resuscitation. And we have evidence on radiology of gross blood, so we go there, and open pelvic fractures as well. So usually for these patients that may require this kind of damage control surgery, we usually stage them. You know, there are stages. Initially, they show up to the hospital. They are rapidly brought. We stop bleeding, prevent hypothermia. The BPs, when the BPs crash, we take them immediately to the emergency room, the operating room, and there's a stage there where we resuscitate, and then there's a stage where we send to ICU, and after achieving hemostasis, and there's a third stage where we bring them back to theater to remove the parts that we left. Yeah, in the abdomen, we usually do quadrant packing. We do soiling control. We go and get intestinal clamps and clamp bowel loops that will be soiling the abdomen. And there's that maneuver, many times called the Pringle maneuver, where we grab the ligament to the liver to prevent bleeding from the liver, particularly duodenal ligament. So grabbing the vascular components in there to prevent bleeding from the liver, the Pringle maneuver. And then we do pelvic peritoneal packing, an incision, lower midline of the abdomen. We can access the abdomen, put a catheter in the bladder. And that interface will do the bowel, and then pack about 3 mops will help us achieve hemostasis, close the abdomen temporarily, and then go to ICU, and then return later to do X-fix. Head trauma, neurotrauma, is important to remember the anatomy of whatever is in the head, starting from the scalp, the meninges, the substance of the brain, the ventricles. It's important to remember to keep the anatomy of the head at the back of your minds. A very highly richly vascularized scalp, and then the associated structures. Now, the pathophysiology, many times in head trauma, lies in this Monroe-Kellie doctrine. The Monroe-Kellie doctrine states that the skull, especially in adults, is a very limited cavity. It's fixed. It's a fixed, limited cavity. It already contains blood vessels, both arteries and veins. It already contains the brain, and it has CSF. So there's no extra space for you to add anything. Should you add a space-occupying lesion like a mass, like a hematoma, subdural, epidural, then the brain will initially try to compensate to maintain a normal intracranial pressure, but soon it will give up, especially if the mass gets higher. And then some contents the skull have to be forced out. Many times the CSF, many times the brain. And now if you begin forcing the brain through orifices in the skull, and then you start compressing some of the vital centers, cardiorespiratory centers, this kind of thing. That's how you get the principle of subtentorial coning. That's how you cone and die, because you're compressing cardiorespiratory centers. So it is crucial that you keep this Monroe-Kellie doctrine and the expanding masses in the skull at the back of your mind as you address pathologies related to trauma to the brain. The other pathophysiological equation you need to keep at the back of your mind is this equation, cerebral perfusion pressure. Cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. Mean arterial pressure you calculate as a factor of the systole and the diastole. Intracranial pressure should be fixed and a low value. So if you play around with this equation, you want to maintain a good cerebral perfusion pressure. You need a decent mean arterial pressure and a normal stable intracranial pressure. When you start to increase mean arterial pressure, if you have a normal cerebral perfusion and normal intracranial pressure, then you're going to have a high cerebral perfusion pressure. It's not good for you if you have, for example, hypertensive bleed. So a patient who is bleeding and is both hypertensive, then it's going to bleed worse. It's going to bleed worse. So similarly, you don't want your cerebral perfusion pressure to be low, because you don't want cerebral ischemia and you don't want cerebral hypoxia. You don't want cerebral ischemia. So you want to keep your intracranial pressure low. So some of the procedures, and the reason you see a neurosurgeon or a surgeon going to theater to do a compressive craniotomy, to do a craniectomy, to do a Barrow's craniostomy, is because they want to keep the intracranial pressure low. You always want to keep the intracranial pressure within normal ranges so that you maintain a good cerebral perfusion pressure. So it's important to keep this equation at the back of your mind as you deal with the consequence of physiology of traumatic brain injury. So I have seen patients die because they had lacerations of the scalp. The scalp is very richly vascularized, and if you do not control hemorrhage of the scalp, you can easily end up with lacerations that can they had. The skull usually fractures, depressed fractures of the skull, or fractures of the cranium and the skull base, the meninges, epidural, subdural, and subarachnoid hemorrhages, and then diffuse axonal injuries in the brain and intracerebral bleeds, commonest injuries. In this picture, you can appreciate, I think, an epidural hematoma here, right here, and on the other side, you can appreciate a subdural hematoma with a shift of midline structures of the brain to the opposite side. So surgical intervention, the neurosurgeon, many times the general surgeon, country, the scalp lacerations, they are doing major surgical toilet and suture to achieve hemostasis. For depressed fractures of the skull, you're doing skull elevation, doing craniotomies, doing craniectomies, and you want to achieve hemostasis. You want to achieve hemostasis, this is the goal, and you plan for your patient preoperatively, intraoperatively, postoperatively. Preoperatively, you want to make sure they are not hypertensive. If they are, the blood pressure is controlled. If you have time, you have a good PTI nurse. Intraoperatively, you control the process. The adrenaline saline you inject in the scalp. You achieve hemostasis with electrocautery. Sometimes you get peroxide